It's Friday, a Health Friday conversation. You know, we always have this. And today we want to talk about, again, universal health coverage, but from a different angle. Heart diseases, okay? When we talk about UHC, we think about everything else. Oh, is UHC going to be able to cover us from this angle and the other? We talk about UHC and then we say, is UHC really focusing on preventive and promotive healthcare at a community level and primary healthcare at that level? Or is it only talking about, healthcare at a level of referral and bigger hospital, level 5, level 6? I think we should even have a level 7 in this country. Is it at that point? But we don't actually go into the details of each disease. Heart conditions. A cardiologist, specifically a pediatric cardiologist, is with us now for the next conversation, Dr. David Githanga. Good morning.
Good morning, Eric.
Thank you very much for joining us today. Welcome to the hot seat of Kenya's biggest conversation. What we do here is we make sure that your heart is beating properly while on that seat.
It is already hot.
It's already Karibu sana. But to welcome you properly into the show, CT has the day's proverb. This week's proverbs have been from the Republic of Congo, Brazzaville.
Yes, not DRC.
Not a DRC.
No.
It's the other one.
This is the Congo.
Without the D.
Yes, that borders the Atlantic Ocean.
Right.
That one.
Mm-hmm.
A tree cannot stand without roots.
A tree cannot stand without roots.
Yes.
Constant had a good interpretation, an interesting interpretation of it. Daktari, what's yours? What's your interpretation of this proverb?
I mean, if you look at it from the face of it, it just makes sense. A tree must have roots to stand. But I think that if we say it's a proverb, which is what we're saying, then it would mean that there are certain fundamental things that need to be there for you to be in a certain way. You are what you are because of how you've grown up, your environmental exposure and your upbringing, your education, those things that formed you. Whether those are good or bad, they are determined by that we cannot see. That's the way I would see it, in a simplistic pediatric way.
Like you're speaking to a 1-year-old.
Yeah.
Thank you. Daktari, we've had several doctors here, cardiologists. What's the name of our friend from the Nairobi hospital who is a specialist on the heart and vessels?
Robert Madenge?
Yes,
Robert Madenge, Dr. Robert
Yes,
Madenge.
they know each other. Same was up.
Literally.
So yours does not have those other long words that Dr. Madenge's title has.
Just forget about this. It's just dealing with the heart. And you can intervene. You can be a specialist of mitral valve or veins in the legs and so on. Okay. But at the end of the day, people are looking for care for their problems. What you call yourself is really a detail. You confine yourself to your professional colleagues.
Okay.
And feel good about it.
Okay.
Yeah.
So you're a cardiologist. Why a pediatric cardiologist?
Yes.
Is there a difference?
Yes. First of all, I look after children. And children are from birth right through to 18. Although in this country, we tend to have a cutoff of 13 years. 12 years. Once you're 12 years, we consider you're an adult. So if you're a 12-year-old...
Medically speaking.
Okay. But that's more for service provision because we have far too many children.
So you can imagine... You would have said 40 because...
you can be 40
Life begins at 40.
Yes, but it's more for service provision so that if you're 13, you tend to move over to the adult section, which is sometimes terrible.
When you now swallow tablets instead of syrup.
No, you're sleeping with an old man and you're 13 years. You're sharing a bed. It's not a good thing.
It's not.
So, but it's just more for service provision. But in developed economies, up to 18-year-olds are really considered pediatric. In even more sophisticated society, they have adolescent medicine, where you look after those children and adults, a mixture of those, which is what that group tends to be.
Where does cardiology then need to focus on those two?
Yes.
When it's pediatric cardiologists, is it that their hearts are different?
Yes, they are different. Heart diseases occur in two large categories. Something you acquire and something you're born with. Very simple. If I want to be complicated, I'd say congenital, but that means you're born with
it.
Acquired is what we will get because of the good living, cigarettes, your whiskeys, and your inactivity. Buy one pizza, get 4 free. That way of living. Inactivity, like what we talked about. You don't want to walk. You want to
Chill.
to have a bicycle that's motorized.
Yes.
So that, you're really just in a car. So those are some of the things that will contribute to acquired heart disease. So children will acquire heart disease as they live like the rest of the people. But there are conditions that you're born with. Means from the very first time you're born, you come out, you have a problem. And those are the congenital groups. And those are largely childhood diseases. Madenge will not see those. However, we also have those children with diseases they are born with that grow up to that age. And we have a fancy term called Gucci, grown up with congenital heart disease. So you can grow up to that level. If you have a very severe disease, obviously you never grow to adulthood, you'll die early. Yeah, but there are those that will have a hole in the heart, and they live with it the whole of their lives. Yeah. So
what are some of these diseases that we're looking at? Of course, hole in the heart is quite prevalent.
Okay.
But then what are some of the other things that we are seeing in children, heart diseases?
Okay. So we have those structural issues that they are born with, but there are also other diseases they acquire even at that age. For instance, you have viral infections that can cause inflammation of the heart, redness, like this microphone, become red, swollen, oozy, and it dilates or gets large and it fails. We call that myocarditis, inflammation of the heart. That's really a disease you acquire from an infection. And some of those diseases can be seen in childhood. But that's an infection. They are not. It's not a structural issue. So largely structural, where you have things that should have formed did not form, things that should have divided out did not divide out, vessels that should have gone to certain places went to other places. All sorts of complications and computations can occur. So the moment you have a child with a heart disease, it can be anything. It can be anything.
Okay. So usually with pregnant women, you will go for scans at some point. And they're looking at you as the woman, and they're also looking at the child at some point, depending on the degree of scan, to see what's going on here. Are there any of these things that you can see at the scan, via the scan at that level and at that age?
Excellent question. Now, at conception, when this baby begins to form, 3 weeks later, you can actually identify the heart. 3 weeks later. But the heart usually starts as one big chamber with one big blood vessel. And then it divides out into 4. Into 2 receiving chambers, 2 pumping chambers, and 2 big blood vessels. But at any stage of that development, there can be an arrest. Where does it occur? We don't know. But we know 8 out of every 1,000 live births will have heart disease. Fortunately, out of that 8 in 1,000, only 2 in 1,000 will be severe and life-threatening. And those that die very quickly, basically within 24 hours, 1 month after birth, they'll die. So we can identify heart diseases. But remember, it's a developmental process that occurs over time. So the interpretation can be very tricky. When I was training in the early 90s, and fetal echocardiography, which is really scanning for the fetus, was in vogue and still in vogue now and important, but it's more sophisticated now. You would have a woman having a scan, and depending on what you see, you'll have to make a decision. Is this an arrested development, or is this a development that is in progress? If it is so severe that that fetus cannot survive, then you may have to be recommending a termination. But situations have occurred where terminations are done, and when a postmortem is done on that fetus, it was not as bad as it looked. So it poses ethical issues.
Of course.
It's a bit like saying this child is taking too long to talk. So do you label them? No, one of their grandfathers talked at the age of 6. So and a lot of childhood issues are a spectrum of things. And that then calls about judgment. When do you say what is what? But to answer your question more directly and not like a politician, yes, you can identify, but you have to decide at what stage. Is this life-threatening? What advice do I give?
So then the importance here is if you can identify at that stage,
Yes.
when the baby is still in its mother's womb,
Yes.
then you're prepared
Fantastic.
for when the baby arrives.
That is fantastic. In fact, a lot of neonatal open heart surgery is very, very complex. Not so much complex because of the little cutting of tissues, but the care after, it's total. I mean, the hospital services are really stretched by open heart surgery. Everything has to work to be A1 in functioning. Your lab, your fluid, your mechanics, your machines, everything has to work well. Otherwise, surgery is perfect, but other things go wrong. So the moment you find or you diagnose that this child has a heart disease, this can only be done or operated on in a very specialized center. Then you want to transfer that mother. You want to use the mother as the ambulance to go with that baby while they're still intrauterine so that they deliver where the surgery can occur. By the time the baby is being born, the system is ready to do what they
Receive
need
this patient.
for that patient. But the moment they're born, then you're in trouble because, and I've had the misfortune of having to fly out patients to London and India, and it's a very hairy thing when you have a small little baby and you're trying to bag, and it's not an air ambulance, so it's a very difficult situation and risky. But many of those, if they are born in centers where you have that expertise, many of those will be able to survive. To give you hope, of the congenital abnormalities we get, heart surgery is one that you actually do things and you basically back to normal in many, many of the conditions. There are other conditions where you can't do anything about. Yeah.
You know, David, I'm thinking
Yes.
the vast majority of our population in this country in the rural areas,
Yes.
just basic healthcare, primary healthcare
Yes.
is a challenge. Now, I think you know where I'm going with this. Now, when you now come to diagnosing, forget even just getting to understand that this problem may exist in a child, so that these processes that are redeeming and these processes that are needful and the processes that promise life, in that setting, they don't exist. Not that they're in small numbers, they don't exist. Are we then saying that because of the non-existence of these processes, that we could in reality be condemning very many unborn children, very many parents who expect and anticipate to have children? We are condemning them to a situation where the hope you speak of will be completely absent.
Charles, to be politically correct, yes, you're right. You're right, it's true. But I like to also say that the eye does not see what the brain does not know. If you don't know, even when it's just right there, you will not diagnose it. It's quite often argued that our patients come late. But actually, that's not true. Our patients come in early, but it's where they go and who they see. A mother is the first doctor to their own child. A mother will tell you there is something not right with this child. And that mother, depending on where she is, she's going to the healthcare provider that she can access. And she says, I don't like this baby's just crying and so on. So they will have gone, they'll have sought for help. But who did they see? Did that person make the right decision? Did this person trigger the mechanisms of referral? That's where I think things go wrong. So we have to begin with education. What are the simple things you see at the most peripheral of levels to be able to trigger the system? To say this person requires help at a level higher than myself?
Yeah.
Or even as a doctor, what do I see that gets me to call a colleague of mine who knows a little bit better about the condition? So that's where the failure is. So we begin by educating the healthcare providers to recognize what they cannot handle and what needs to be moved.
Accept your limitations.
Exactly. And that's hard for many people. Many people think asking is being weak.
Yeah.
In fact, it's a strength.
You know, within the health provision fraternities, you have other health practitioners who are not medical doctors. You have nurses, you have clinical officers, you have community nurses, and so forth. Now, the specialized knowledge such as the one that you have, is this cascaded to those other health professionals? So that, because if you're talking about primary health care, these are the individuals you might find at those levels. Not necessarily a medical doctor. No, forget even the specialty, just a medical doctor. Do we have, or is there an existence of training that is provided for these individuals whom most of the people who are seeking healthcare in this country actually come into contact with?
I think there is some version of that, but remember we said it begins from a mother or a parent recognizing that there's something wrong, then you seek help. We have then various cadres, and they can be very different. They can all be nurses, they can be all community health volunteers, they can be younger doctors, or even sometimes older doctors. What is their abilities to recognize a situation and act on it? So these issues do exist. In fact, nurses, some of the older nurses are very, very sharp. And as a young doctor, when you qualify as a doctor, you walk around with the DR in front of your name and you think you're great. Until you make several mistakes, until you look down on those nurses, and then it calms you down very quickly. That lady knows
more than
you do. But since you bear the name DR,
you're the one in charge.
The folly of youth. But you learn over time, and the older nurses or the sharper nurses are the first ones to tell you, Doc, I think there's something we're missing.
If it is a folly of youth or is a folly of training?
It may be a bit of both, I don't know. It's a philosophical question.
And society as well. I mean, I'm the one who spent 6 years.
Yes. Who are you?
Who are you to tell me?
You only went to KMTC there or some
It
nursing
doesn't
school.
start there. I'm the one who got those very serious grades.
I'm the one who got an
me
A.
into medical school.
Yes.
So please.
Notwithstanding that you had an exam leaked for you. I didn't say anything.
You don't go that far. Let's just deal with it. You got an A. Okay? And you went to med school. And you spent 6 years. Right?
Yeah.
Okay. So is it how do you balance, how do you train these young doctors? Because I'm sure you train.
Yes.
How do you train these young doctors, wannabe doctors, to actually respect everybody in the ecosystem?
First of all, it's by medicine is an apprenticeship. You see how your colleague deals with the other colleagues, and a doctor spends probably a relatively shorter period of time with the patient compared to the nurse. Or even a parent. That's why you must listen to a parent who is telling you something. They are not lying. It's their own interpretation of the situation.
Best interest of this child.
Exactly. So you're on the same side, and you must see her or him as your partner. So a younger doctor has to see the way you interact. That's why you shadow an older. Even now, I like seeing some of my older colleagues just even explaining a difficult situation. I just sit back and just listen, and that's how you learn. You shadow somebody else, and you learn to know. And the older you get, the more you know you don't know many things, and you have the grace to say I don't know. And one of my best teachers is a senior professor of pathology who would always, if you ask the question, say I don't know. I just don't know. But tomorrow morning, he will know. He has not slept. He has checked out. And the abilities to say you don't know then triggers you looking for help. And then when you do that and you question, then the people who are understudying you do.
They'll pick it up from you.
Yeah, they pick it up from you.
Dr. Githanga, we're having this conversation with UHC in mind.
Yes.
Now, universal health coverage is a conversation we've been having in this country for many years. We hope to actualize it within the next 2 decades, at least
2030.
You know, at least one of those days it'll actually
2022 it was, wasn't it? That's last year. I think.
Yes. So 2022 now we move it. So I'm just saying, let's just
moving target.
Let's give it another 20 years.
Yeah.
One of those days it'll come to pass.
Yeah.
But then when you talk about now pediatric cardiology and UHC, it's all about access. What are the affordability bit of it? Let's talk about the access. First, it's a heart issue.
Mm-hmm.
I want to go back now to start my question from the way you said. It's possible for this to be detected early enough when the baby is still developing intrauterine. During these antenatal visits, this is where primary health care comes in. And this is where every expectant mother is then encouraged to start visiting health facilities for antenatal care. And this is where issues with the developing baby will be picked up. Now, how should our system be structured so that by the time this baby is about to be, the mother is about to be delivered of the baby, speaking the Queen's language. By the time this baby is arriving, people like Dr. Githanga are aware that there is a case that I need to attend to. How should we structure this system?
That's an excellent. I can see you've been reading a lot about primary healthcare. First of all, history is very important. And when you look at the parameters of care, antenatal visits is one of the parameters that we measure. Unfortunately, the minimum number of visits should be 4. That's one of the parameters that has not actually improved as well as it should have been. We'd expect that and that level is not chargeable now, it's free. But people still haven't gotten to getting the antenatal clinic follow-up being done as well. And that's where you detect these issues. So if we ramp up that and say this is important, the first visit, the second visit, the third visit, fourth visit, because that's how you follow up the progress of the pregnancy. If, say, we succeed in that, and that's also dependent on the seeker of the service, then you'd want to make sure that the people that are giving those services are sufficiently knowledgeable in being able to take history. For instance, if a mother gave birth to a baby in the past and that baby died immediately, if we do not have the postmortem of that baby that died, or we have no way of making a diagnosis retrospectively, then you'd want to suspect that there was something about that baby that probably should have been known before.
Yeah.
So that becomes a high risk. That mother is elevated. That mother is escalated to a higher level, so that that mother will have probably an ultrasound being done relatively early, and the system will push that mother upwards. But note, it's very dependent on the person giving those service. If you do not think that way, then you end up having the same sort of thing until a mother says, "This is my 4th baby I have lost," which is terrible.
Asking
It's
yourself,
system
okay,
failure.
so really 4th?
Yes.
What happened to the others?
Yes,
And they don't know.
yes, they don't know. They didn't question.
Yeah.
Yeah,
So it has to start with, first of all, the caretaker.
caretaker.
Awareness that as soon as I, confirm pregnancy, I have to do 4 visits.
Yes,
And
minimum.
Minimum 4.
Yeah.
And then the caregiver at that level to understand what they're looking out for. Not
Yes.
just, umekuja, haya, unasikiaje? Kichwa?
Shida yoyote?
Haya, next time utakuja.
That's it.
Swallow your eye on the folic acid. Yes.
Meza folic acid. That's it.
Yeah.
Let's continue the conversation after this break.
This is the Situation Room, the only way to start your day.
Ndu, ask Dr. David Githanga a question.
Okay, so would you, as a doctor, medical professional, would you, having seen the dangers in a potential situation, recommend termination to an expectant couple, mother, father, whatever?
Thank you very much. That is a very difficult question, and one that gets you to wish that your teacher was there to answer the question. See, I'm junior here. That's not a question that is easy to make. For you personally, it is, but you always think about the patient or that mother. truth of the matter is that there are conditions that are life-threatening or will be uniformly fatal. We know a number of heart conditions that you diagnose, and you know that if you do not have this patient operated on within the next 24, 48, 36 hours, they are going to die. And those are some of the situations in ideal circumstances that you'll get a mother to deliver where she can get an open heart operation for a newborn. If, say, I was in Lodwar or another place that doesn't have that facility, what would I tell this mother? And I had made reasonably good diagnosis that this is a life-threatening condition that baby will not survive without an operation. You just are as honest as possible, as kind as possible, and I would use words like, this is a difficult condition, it would need an operation. And there are some, even those that are born in those sophisticated centers, even when they undergo an operation, they had a univentricular heart, one chamber instead of four. Even those will not survive. Even for that particular mother, you have to be quite open with them. I am a pediatrician, I'm a pediatric cardiologist. The surgeons will say, we'll operate on anything. That's how we develop science. I said, no. I think about my patient. I think this patient has a very difficult situation. We will probably go through multi-stage operations, the end of which they may live to another 3, 4, 5 years at high cost, and they will die. But you have to be gentle with the way you give that information and leave it to them. You cannot place yourself at that high level, high stool, and you're telling her what to do, because she has to live with that decision.
Looking at this, looking at now the burden of care on a system, right?
Yeah.
We're saying that certain parts of the country you will not be able to get the healthcare that you need. Then saying, because if we're saying universal, that means being able to go and get what you need when you need it, to the measure that you need it. Right? But here you are, and you have seen from your practice and your knowledge and your understanding, you know that even if at the instant you would be able to save this child, at that instant with the surgery, that they will probably go into the rest of their life with a compromised or depressed system, number one. Number two, that they will not live their optimal because of this condition. And you know that they will also go in probably with having to frequent a medical facility more than normal. How do you deal with that?
Very not well. One of the burdens of being a doctor is knowing a lot and probably telling the patient just 2% or 5%, particularly when it's terrible news. When you speak about survival rates, and there are many, many diseases where we're getting better each time. If I say this disease in the 40s, survival rate was 20% for 5 years, but now we are 80%. That never really makes any sense to that particular patient, because if they are the 1% that did not do well, then that's 100% for them. Bad outcome. The point is, you know that there are certain conditions that it doesn't matter what you do. There are certain conditions, heart diseases, that we know by the time they are reaching their 30s, that's it. They will just die. Let me give you a simple example of an acquired heart condition, and that is children with upper airway obstruction, large adenoids who snore. Most men will snore. Ladies will catch up by the time they are 50, 60, so there is no difference. But when children snore, it tells you there is obstruction that's mechanical. We snore because of floppy tissues. But when children who are very taut tissues snore, then it's telling you there's upper airway obstruction, adenoids. You may have heard of adenoids. Adenoid enlargement that is unattended when they are very large causes a secondary heart disease, right? They will have right heart failure. Once they get pulmonary hypertension, which is really pressure in the lungs, that child will die early. They will live to probably 25, 26, 30. They will die early of pulmonary hypertension.
Mm-hmm.
So we know that. We know that. So if it is something like that you understand very well the history, then I'd say I would recommend that this child undergoes upper airway obstruction surgery, adenidectomy, and that will relieve us of that potential and you can be relatively firm with that.
Yeah.
Then the question they'll ask you, what are the risks of surgery? Say everything is a risk, including drinking water and having additional oxygen. So it's a question of there are people who take aspirin and bleed to death. So you would have to weigh the balances. So it's never really a straight line when it comes to life, quality of life, who decides who lives and who doesn't.
Sure.
And if you ever worked in an infertility clinic, I remember that as a young doctor, mothers who are trying to get a baby, they're pleading towards the end, please give me one, even if they are retarded, just for me
I just want a baby.
I just want a baby. Yeah. So when you have all these facts, it's very difficult for you to say, I'm recommending this.
Cannot go and just say I recommend.
No.
And even in the cases where you go and advise, and your advice is basically leaning towards a strong recommendation for termination.
Yes.
It depends on the mindset of this mother, right? Yeah. Because at that point, this woman is just thinking, I have a life growing in me, and I'd like to see this life.
Yes.
To see through that I've delivered this life.
And it was mine.
And it's mine.
Yeah.
So it's also a very difficult decision for that mother at that point to make.
Yeah.
They may think about it later and say, okay, I wish we had done this earlier because of the frustration that they've gone through of, taking care of this child and watching the child suffer. But at that moment when they're pregnant,
excitement.
It's excitement.
There are people who have parties 24 hours after they confirm pregnancy or they have conceived.
Especially in my neck of the woods.
Yes. So you are not going to remove that joy by saying terminate.
UHC. Now let's just begin with the current situation.
Let me just go back a little bit.
All right.
We, however, recommend termination if, say, a woman came in, had an X-ray, and in the first 3 months of pregnancy, because we know radiation, ionizing radiation, can cause serious effects on the fetus. That is why, as a standard measure, we'll ask, when was the first day of your last menstrual period? Try and rule out that you're not pregnant.
Before an X-ray.
Before an X-ray. Yeah. So those are now a bit hardline.
Okay.
But that's now a mistake that has happened that you didn't ask that question.
You didn't ask the question. Yeah. Or in some cases, maybe this person has a very irregular cycle.
Yes, true. And that does happen.
And the last time may have.
Yes. So you would now be seeing very high chances of, and nobody will tell you 35, 45, 85%, but you've just been irradiated. And these are the risks. You would recommend, but it's not up to you.
Wow. I wanted to ask the current situation, UHC, NHIF, right? You're practicing. Many questions, even as we posted this on social media, people are asking, all right, so first of all, to what extent does NHIF presently cover, these heart conditions and dealing with heart conditions both in private and public hospitals?
Yes, I think, first of all, UHC, NHIF has been in existence since 1966. And for the last probably 50, 60 years, probably the coverage is 50-something%, 52, 55%. And covering that is not widespread. It's even in that 55%, it's not equitable. Certain people do not have it, and those that have it comfortably, they can afford to pay for it. They have probably a better version of it, so they get the better service. So there is even, if you like, inequity, even in even in that space. And you would find, particularly when we started having all these very, very good packages, many people were getting their open heart surgery using NHIF, particularly being able to go to India and so on. But those are the ones that had probably better packages and so on. So we still have a big proportion of people who do not have that capability. And heart surgery can be expensive. Some heart surgery would cost you anywhere between 200,000 to $1 million and 1.2 million. If you stay in the ICU, 3, 4, 5 million is not surprising. So they can, depending on how long you stay and how complicated it is. So it does cover in principle. But the truth of the matter is that you need those numbers to increase so that you can cover more. And not everyone needs very, very complex surgery. Some of them have basically a blood vessel that needs to be clipped off, like what Dr. Githanga is saying. Interventional cardiologists, you have this vessel that should have closed. You just put in a plug there, basically just knock it off, and they're able to go home the next day. So those are simple and they are not that expensive. The other spectrum is a more complicated one that could be costly. So in simple terms, yes, it's covered, but how much are you able to cover? Because this can be an open.
Oh, sorry. And is most of the care that we are talking about here that could essentially be covered by NHIF and this whole UHC, is most of it surgical care? Because it's a one-time thing and then you're done. You cut, no pun intended, but you're done. Or are we talking about, longer term care for heart patients, which could then also get really expensive? And you're given the example of Lodwar, where you spoke, where, the facility doesn't exist. So you have to travel somebody, you do the surgery. But then what happens with aftercare, which also can get pretty expensive?
The good news about children, say you have a hole in the heart, once it's
you're done,
patched,
you're done.
that's it. That's one off. It's done. You're not going to be doing that. However, there are some that say you have rheumatic heart disease, you have a leaking mitral valve. You need a monthly injection, basically, for the better part of your life. You need to take some pills for the better part of your life. Those exist, but a large number of pediatric conditions are actually a one-off.
Okay.
A one-off situation.
So it's surgical and you're finished.
Surgical and you're finished.
Okay.
When you begin to go to adults now, that is now your hypertension or diabetes and so on. Those are the ones that drag. Those are the ones that are now expensive in terms of the visits. A few of the younger children that survive, some of those may behave like adults. They're grown up with congenital heart disease, but those are few. But the question you're asking, why are you excluded by even the private health insurance? That is something that we've always fought about, but I am a provider, so on one hand, I'll be on the patient's side. Technically, insurance will tell you anything you're born with is not covered. It's going to be in a small print, font 2,
like that,
in italics at the bottom. It says you're born with an extra finger, that you're born with it.
If you want to take it off, you pay for it.
You pay for it. Yes. And say, this is the one-off. It costs you more to look after an asthmatic than paying for that little surgery, or even a belly button that's larger. It's still congenital, you're born with it. But that is me arguing as a provider with a person who is a profit maximizer. Sorry, I take that.
I have to write that down.
I pay that back. We need insurance.
The debate around universal health care, this CNH thing is getting in the way of this, my discussion. The inequity that people talk about with regards to UHC, it's as if it is possible for there to be universal equity, forgetting healthcare. I mean, I brought in a philosophical angle to it. But perhaps should the discussion not be how to recognize that inequity exists and how we can bridge it, rather than speaking as though it is something that is actually possible. It actually isn't possible. It has to be a continuous, lifelong work in progress.
There must be inequity.
Yes, there must be inequity. There is always inequity. Inequity, rather, not iniquity. inequity. Yeah, not iniquity.
Not iniquity.
Well, even that also exists.
There's also iniquity.
Yes,
as well.
but that's what I'm referring to. The inequity that we speak of is often a manifestation of that iniquity that we're talking about. So how do you bridge this gap so that the people who need this healthcare probably the most, simply because they're economically disadvantaged, are in a position to actually benefit? That, in my mind, is the discussion I would prefer. I'd rather have.
Is Charles, you're right that this is a philosophical question, and I see the spirit of Good Friday has
descended upon you.
The poor will always be with us. Truth of the matter is that societies will only be different. I mean, and it's not even in our interest that all of us are the same. Otherwise, you not have a driver, you not have somebody to service your machines, you not have somebody to do your nails,
you don't have someone to employ you.
You don't have somebody to fly your private jet. So we can't. It's not in our interest. So that would be there, but it's actually when the threshold is so low that people cannot get certain services that they require. And we know that will always exist because that's just the nature of things. There is, even your fingers are just different. They have different functions. But in terms of health, and health is something you need to be able to create wealth for a country. And when you're a leader of a country or an organization, your investment in health is dependent on your own philosophy. Do you see health as an expense, or it's an input to enable people to be healthy so that they can produce wealth? And that way of thinking then shapes how much you give. But also as a society, you cannot let certain groups of people just fall below the threshold. There must be a threshold that a safety catch for people who are at the bottom. So knowing that situation of inequity will always increase, it's really the gap. You must minimize that gap. Things that can be sorted out. Why should a child be dying of pulmonary hypertension from adenoids that could have been operated on? That is not right. So it's the gap.
And this is where the social angle of the government comes in, right? It must focus on setting aside resources to address these levels of inequity.
Exactly.
And make sure that these people can get access, which is what UHC is trying to do.
Yeah.
Well, the general principle of UHC is to make sure that at least everybody has access to some basics.
100% coverage if you can. If you live, say, in the Scandinavian countries, and it's everybody goes to the same place.
Yes.
There is, in fact, private care is almost frowned upon. It's probably for big stars who want to go to some place and have their little
because they have some secrets.
Or some. And I must look younger tomorrow. Have some.
I have a thing tomorrow, so you know.
I have a thing tomorrow, so you can. But people get the same thing, but that's related to taxation. They have a wide tax base, and they are wealthier governments. But also, the utilization of their equivalent of NHIF is efficient, because inefficiency is part of the disbursing. You collect and you disburse. So probably part of the solution is you source the services, but somebody else will collect, so that you separate those two. So it is related to how you set up your services. It's in the interest of all of us. It doesn't matter how wealthy you are. I've seen very, very wealthy people die impoverished by just medical bills. They say you will use your health to gain your wealth. In the last 5 years, you'll use all your wealth to try and get back your health. So all of us can end up that way. It doesn't matter who you are. And any amount of money can be finished by medical services. So it's in the interest of all of us to have those services. And I talk on behalf of Charles and myself. We are aging, so we need to be. We are a vulnerable group.
And you're also a minority.
Increasingly. In my village, I'm called old man.
In this country, you're like, what? How many are you? Like 10,000 of you?
We are an endangered species.
Even wow.
Dr. Thank you very much for joining us today. A pleasure having you. Dr. David Githanga is a pediatric cardiologist. He's been here telling us about heart diseases and talking about UHC.